Hello everyone, welcome to today's physiology session. Today I am going to discuss movements of GIT. We all know that the consumed food needs to move continuously in the GI tract. The rate of movement is different at different part of GI tract and depends on various neural and chemical factors. Here we are going to discuss 6 movements in GIT. First one is mastication, or it is also known as chewing. Second one is swallowing or deglutition. Third one is movements of stomach. Fourth one is movements of small intestine. Fifth one is movements of large intestine. And sixth one is defecation. So let's discuss each of them in detail. First one is mastication. Mastication is the process by which food is taken in the mouth. It is crushed into small pieces by the grinding action of teeth. The anterior teeth, we all know that incisors are canine, and it is a first mechanical process in the GIT by which food substance are cut. And let us discuss the muscles of mastication. First one is masseter muscle, second one is temporal muscle, third one is pterygoid muscle, and fourth one is buccinator muscle. And coming to movements of mastication, there are mainly 3 types: opening and closure of mouth, rotation movements of jaw, protraction and retraction of jaw. It is an illustration of mastication or movements of food inside the mouth. We can say that the food particles are chewed inside the mouth by the teeth and the palate, and it is transferred to the esophagus. Next movement is swallowing or deglutition. It is a process of transfer of food from mouth to the stomach. It has both voluntary and involuntary phases, which is known as deglutition reflex, since a major part of deglutition process is under involuntary control. There are mainly 3 phases: oral phase, pharyngeal phase, and esophageal phase. Oral phase is mainly voluntary phase. At the same time, pharyngeal and esophageal phase is involuntary. Oral phase is from mouth to pharynx, pharyngeal phase is from pharynx to esophagus, esophageal phase is from esophagus to stomach. Let's explain each of them in detail. Before that, it is an illustration. First one is mastication or chewing, which is called as preparatory phase. In this phase, the food is get chewed or cut into pieces inside the mouth. And then oral phase, the food is present in the mouth. Okay, then it is pushed backward by the pressure of tongue against the palate. In the pharyngeal phase, it will reach the pharynx, and in esophageal phase, it will transfer to the esophagus. So let's explain. In the oral phase, it is also known as buccal phase. It is a voluntary phase, which is called as chewing. In this, the chewing process is done, and it is pushed backward by the pressure of tongue against the palate. Once the food touches the pharyngeal opening, the receptors are stimulated and swallowing reflex is initiated. Next one is pharyngeal phase. It is a partially an involuntary phase. As the food enters the pharynx, stimulation of receptor around the pharyngeal opening initiate the impulses and pass through the brainstem. This initiates a series of complex changes that allows the food to pass through the pharynx. Okay, since pharynx communicate with mouth, nose, larynx and esophagus during this stage of deglutition, bolus from pharynx can enter into mainly 4 parts, which are back into mouth, upward into nasopharynx, forward into larynx, and downward into esophagus. There are 4 possibilities for the food to move in. However, due to various coordinated movements, bolus is made to enter only the esophagus. Entrance of bolus through other path is prevented as follows. First one is back into mouth. Return of bolus back in the mouth is prevented by position of tongue against the soft palate, roof of the mouth, high intraoral pressure developed by movement of tongue. Second one is upward into nasopharynx. The movement of bolus into nasopharynx from pharynx is prevented by elevation of soft palate along with this extension called uvula. Forward into larynx. Movement of bolus into larynx is prevented by the following action. First one is approximation of vocal cords. Second one is forward and upward movement of larynx. Third one is backward movement of epiglottis to seal the opening of larynx or glottis. All these movements arrest respiration for a few seconds, which is known as deglutition apnea, which is a clinical condition. And the fourth way, which is a possible way that food will enter into the esophagus without going to other three paths. As the other three paths are closed, we have already discussed about that. The bolus has to pass only through the esophagus. This occurs by the combined effect of various factors. First one is upward movement of larynx, such as the opening of esophagus, and simultaneously upper part of esophagus relaxes. Third, at the same time, peristaltic contractions start in the pharynx. Now let's discuss about the third phase or esophageal phase. It is also an involuntary phase. It has got two sphincter, upper esophageal sphincter and lower esophageal sphincter. In this stage, the food from esophagus enter the stomach. Esophagus forms the passage of movements of bolus from pharynx to the stomach. Mainly, it exhibits two types of peristaltic movements, primary peristalsis and secondary peristaltic contractions. Primary peristaltic contraction, when bolus reaches the upper part of esophagus, the peristalsis starts. It is known as primary peristalsis. As soon as the food enters the esophagus, the upper esophageal sphincter contracts, preventing the regurgitation of food into the mouth. Gravity does not play a major role in this process. At the same time, the wave of peristaltic move at the speed of 2 to 4 cm per second. As the wave enters the lower esophageal sphincter, it relaxes and allows the bolus to easily enter the mouth. Now, secondary peristaltic contraction. If the primary peristaltic contractions are unable to propel the bolus into stomach, the secondary peristaltic contraction appear and push into bolus into stomach. Some amount of food may remain in the esophagus even after primary peristalsis is completed. This touches the mechanical receptor present in the esophagus, which initiate another peristaltic wave. This is called secondary peristalsis. It is coordinated by intrinsic nervous system of esophagus. The secondary peristaltic wave continues till all the food in the esophagus is emptied into the stomach. Here we can see the illustration of peristalsis, and it contains area of contraction and relaxation. Peristalsis means is a position change of the food. An area of GI tract is contracted and another area is relaxed, so that food is will change the position or transfer its position from one position to another. That is the peristaltic movement. Now coming to deglutition reflex, there are 5 components, mainly stimulus, afferent fiber, center, efferent fiber and response. Stimulus is entry of bolus into oropharyngeal region. Afferent fibers are glossopharyngeal nerve. Center is medulla oblongata. Efferent fibers are glossopharyngeal and vagus nerve. Response is upward movement of soft palate to close nasopharynx and upward movement of larynx to close respiratory passage. Now, movements of stomach. Let's discuss. It is mainly hunger contractions, type 1, type 2 and type 3, then receptive relaxation and peristalsis. These are the main movements of stomach. First one is hunger contraction. Type 1, they are mild movements occurring at the rate of 3 per minute. Those are discrete movements. Now type 2 hunger contraction, they are stronger movements called hunger contraction. They are rhythmic, tetanic peristaltic contraction lasting for 2 to 3 minutes. They are more intense in healthy adults. The hunger contractions are increased by low blood sugar levels. And type 3 movements, they are occurring condition of extreme hunger termed as hunger pangs. They begin 12 to 24 hours after the last meal and reach the greatest intensity in 3 to 4 days. They gradually weaken in the succeeding days. It produces pain in the pit of the mouth. Next is receptive relaxation. It's a relaxation of upper portion of stomach when bolus enters the stomach from esophagus. It involves the fundus and upper part of the body of stomach. Its significance is to accommodate the food easily without much increase in pressure inside the stomach. This process is known as accommodation of stomach. It causes increase in volume of stomach. It causes by the vagovagal reflex originating in the pharynx and esophagus. Next is peristalsis. It begins as soon as the food enters the stomach. It starts in the form of small indentation on the wall and encircles the middle part of the stomach in the form of a ring. Later it proceeds towards the pylorus. The stomach passes through the pylorus till the pyloric sphincter. Now it is illustration of peristaltic movement. Here the contractions are initially weak, but the gradual increase in the strength. Each time the peristaltic wave passes through the wall of the gastric antrum, the contractions dig deeply into food contents in the antrum. As each peristaltic wave reaches the pyloric region, the pyloric muscles contract and contents are pushed upward. These two mechanisms help in mixing of food particles and secretions. Hope you all understand. And the next is a condition which is gastric emptying. It is a process by which the stomach empties in the contents into duodenum. Normally the pylorus remains closed, partially allowing only fluids to pass through it. Whenever the food is present in the stomach as chyme, the contractions become intense and cause gastric emptying. It causes till the stomach is totally emptied, and this pumping action is called pyloric pump. Okay. Now coming to types of movements in small intestine, which are mainly mixing movement, propulsive movement, peristalsis, and movements of villi. Mixing movement contains segmentation movement and pendular movements. Propulsive movement contains peristaltic movements and peristaltic rush. Before that, let's discuss about factors regulating gastric emptying. First one is consistency of chyme. The rate of gastric emptying depends on size of food particles, and liquid empty faster compared to larger food particle. Next is volume of food. Increased volume of food in the stomach causes stretching of the stomach wall. Next is hormones. Gastrin, cholecystokinin, secretin, and GIP affect the gastric emptying. Now let's discuss about the movements of small intestine. Mainly we discuss in the mixing movements, segmentation movement, and in propulsive movements, peristalsis. Okay. It is a small illustration of peristalsis and segmentation. In peristalsis, the chyme is propelled through the small intestine by peristaltic waves. Normally 3 to 5 hours are required for passage of chyme through the small intestine. It is the position change mainly. The food will change its position, the movement from one position to another. That is a peristalsis. And in segmentation, when a portion of small intestine gets distended with the entry of chyme, the stretch of intestinal wall elicits localized constriction spaced at interval along the intestine. At one set of segmentation contraction relaxes, a new set begins between previous contractions. These segmentation contractions stop the chyme 8 to 12 times a minute. Segmentation is mainly a mixing movement. At the same time, peristalsis will change the position of food from one place to another. It is a simple illustration which shows the peristaltic contractions are responsible for forward movement and segmental contractions are responsible for mixing. Next is movement of large intestine, which also contain segmentation contractions and mass peristalsis. It shows sluggish movements, but these movements are important for mixing, propulsive, and absorptive functions. And coming to the last movement, which is defecation. In defecation, the rectum is empty most of the time. When a mass movement forces the feces into the rectum, a desire for defecation is initiated. Defecation occurs if the conditions are favorable. Here we have two sphincter, internal anal sphincter and external anal sphincter, which is composed of smooth muscle. External sphincter is composed of striated muscles. Let's explain defecation reflex with a figure. The first one is the entry of feces into rectum causes its distension. The afferent signals are initiated in the myentic plexus. It results in formation of peristaltic wave in the descending colon, sigmoid colon, and rectum. The movement of feces towards the anal canal relaxes the internal sphincter. Defecation occurs if the external anal sphincter is also relaxed. The contraction of abdominal muscle helps in process of defecation. If circumstances are not favorable, the defecation is inhibited by voluntary contraction of external anal sphincter. Soon the internal anal sphincter and rectum also relax. The reflex disappears but reappears a few minutes later. It is the defecation reflex. Now coming to applied physiology. It is a common clinical condition which is called diarrhea. It is produced due to rapid movement of fecal matter through the intestine. It is accompanied by loss of large quantities of fluid and electrolytes from the body. It will cause diarrhea is caused by mainly by enteritis or psychogenic diarrhea or intestinal bacterial flora. Enteritis is an infection of the GI tract caused either by virus or by bacteria. The mucosa became extensively irritated and secretion became greatly enhanced. There is a passage of loose stools also. The toxins secreted by pathogens cause secretion of large quantities of fluid and electrolytes. Coming to psychogenic diarrhea, it is caused by excessive stimulation of parasympathetic nervous system, which increases both motility and secretion of mucus in the distal column. This results in passage of frequent loose stools. And it can also the diarrhea can also caused by intestinal bacterial flora, which supply vitamin K and vitamin B complex. They have important role in preventing infection. Now next applied section is ulcerative colitis. It is a disease in which extensive area of large intestine become inflamed and ulcerated. The motility of ulcerated colon increases significantly. As a result, patient has repeated loose motion. And the next applied condition is megacolon. It is congenital condition characterized by absence of intrinsic nerve plexus or oblique plexus. It results in accumulation of fecal matter resulting in distension of sigmoid colon, which is a segment of colon with improper defecation. And the last applied condition is constipation. Occur mainly due to decreased bowel movements. Symptoms including anorexia, abdominal discomfort and distension. Chyme stays for a longer duration in the large intestine, causing increased absorption of water. This causes hardening of feces and difficulty in defecation. So that's all about the applied conditions. And that's all for today. Thank you.